You all know that we have a lot of imaging modalities to deal with the gastrointestinal tract, starting from the plain X-ray and the old-fashioned barium studies, as well as the ultrasound, the CT, and the MRI. And you know that the barium is now, the use of barium is now declined extensively. Its use is no longer one of the ways to diagnose the gastrointestinal tract pathology, but sometimes we need the help of this technique. And this is the old appearance of the barium, and this is some of the new preparations which are flavored by too many items. And the barium is very good for the esophagus, for the stomach, and the small intestine, as well as in the colon. And dealing with barium studies for the gastrointestinal tract, we have four main pathologies regarding the appearances of barium. The first one is what is called filling defect. The second is ulceration, the diverticulum, and the distriction. By filling defect, we mean that we have a lesion that prevents barium from filling this area. And this filling defect may be intraluminal, as you can see this filling defect inside the esophagus, or may be extraluminal, compressing the gut from outside, as in this example by giant osteophytes compressing the dorsal esophagus. Then this is an example of filling defect in the stomach representing a malignant lesion, and you see how it is nicely delineated by barium in what's called the double contrast barium mean examination. And this is also a filling defect along the gastric greater curvature, characteristic of malignant neoplasm due to the irregularity of the margin of the lesion. Then this is a filling defect in the colon, and boulavoid filling defects in the colon are usually suspected to be benign if they have pedicle, and if they are sessile, they may be benign, but most likely they will be malignant. Then you can see this double contrast barium enema, and you can feel this the presence of this filling defect along the proximal part of the descending colon. The stricture may be one of two, either the smooth one, which is known as rat tail stricture, or the irregular one, which is known as apple core stricture. And apple core stricture is diagnostic and pathognomonic of malignancy anywhere in the gastrointestinal tract, while this type of the stricture may be benign and may be malignant as well. And this is an example of an apple core stricture in the distal part of the esophagus, diagnostic of esophageal carcinoma, and a similar one in the middle part of the esophagus with what is known as proximal shouldering and distal shouldering. This is diagnostic also of esophageal cancer. Then this is a stricture in the pyloric canal of the stomach, and you can see dilatation of the proximal part containing a lot of food residues. And you can appreciate easily the irregularity of the gastric margin and the destruction of the mucosa, diagnostic of malignancy. Apple core stricture is very diagnostic and pathognomonic for carcinoma in the colon, and this is nicely delineated in this part of the colon. And you can see the destruction of the mucosa and the proximal and those distal shoulder. Also, you can see here, this is another example of sigmoid carcinoma showing the classic apple core configuration with what is known as proximal and distal shouldering destruction of the mucosa. And ulcers may be benign or malignant, and we usually look to the ulcer as benign if we can see the mucosal folds reaching the edge of the ulcer. But if the mucosal folds are stopping away from the edge of the ulcer, and we think of a malignant lesion. This is an example of a benign ulcer in the stomach, and you can see the mucosa is reaching to the edge of the ulcer. And this is an example of malignant gastric ulcer. You see this mucosal fold has been interrupted here, and it does not reach the edge of the ulcer. Nowadays, we are depending actually on the CT scan by its great newly developed facilities for evaluation of gastrointestinal tract neoplasm. And there are a lot of indications in this particular domain in the assessment of the primary lesion and the tumor spread inside the abdomen and pelvis. In order to have a CT scan of the abdomen, we used to use this oral contrast media known as the gastrographin. And this gastrographin is available in bottles 100 milliliter, and we use only 15 milliliter added to 1.5 liters of water, and let the patient drink this amount over 2 or 3 hours. Then the aim of this gastrographin is to delineate the gut. So if you have a CT section in the abdomen, and you can see that the gut is filled with the orally administered contrast, and if you have a CT like this, and you can see orally stained loops, but non-filled other loops, and you know that these other loops are pathological. Then we think about the pathology according to the site of the loop and according to the clinical picture available. Also, if you have a CT scan on the abdomen and you see a mass inside the abdomen, and you can easily appreciate that there is a loop filled with gastrographin running inside the mass, then you know that this mass is of bowel origin. And you try your effort to know which bowel is this one. If this is the small bowel, most likely you are dealing with lymphoma, most likely. And if this is the large bowel, then the carcinoma is the possible diagnosis. And I will show you some of the examples where we can use CT to diagnose gastrointestinal malignancies. This is an esophageal benign tumor leiomyoma. And the picture in barium was very classic actually in the old days. But if you see this appearance, and you see this is the air in the esophageal lumen, and it is eccentric. The air is not actually inside the center of the mass. Then you know that this is an eccentric pathology, which is one of the characters of leiomyoma in the esophagus. But if you see that the air of the esophagus is in the central part of the lesion, and sometimes the esophageal lumen is almost totally obliterated. In these situations, we used to give gastrography to delineate the very narrow lumen inside the tumor itself. And this is a good example of esophageal cancer in the upper part of the esophagus. And you can not differentiate lymphoma from carcinoma if you have this appearance. And you can see this is gastrographin in the esophageal lumen. The esophageal lumen is in the center of the mass. Then you know that this is malignant. But if you can see the lumen is eccentric, and you feel that it's most likely being a benign lesion. But this is also an example. You see the eccentric position of the esophagus, but this is not actually a benign lesion because of the invasion of the adjacent cardiac chamber. And you can see this is the site of the left atrium, and you see a big bulk of the mass infiltrating the esophagus. This is also a case of esophageal lymphoma. You see this is the esophageal lumen, and this is the main bulk of the lesion. You can easily reach the histopathological diagnosis by endoscopy in such cases. Our main aim is to identify the site of the tumor, the length of the tumor, and if possible, you can see invasion of the adjacent structures and possible metastatic deposits. This is the stomach, where you give the patient oral contrast, and you see a large mass infiltrating the greater curvature of the stomach, diagnostic of gastric carcinoma. And this is a stomach where you give gastrographin, and you can see this mass which is bulging outside the gastric lumen, and also involving the proximal part of the duodenum, which are stained by the orally administered contrast media, diagnostic of a malignant lesion. Then if you look here, this is the CT scan, and this is the stomach, this is the liver, the spleen, and the kidneys, and this is the site of gastric fundus. And you can see that there is marked reduction of the lumen and severe infiltration of the gastric wall on both sides by this malignant neoplasm. Also, you can diagnose the guest tumors, but you are not sure about the histology. Whenever you see a well circumscribed mass protruding mostly outside the gastric lumen, and you can see this is the stomach, this is the fundus, and this is the pyloric canal, and you can see this well circumscribed soft tissue mass bulging from the greater curvature of the lesion. Also, this is a tumor, and this appearance is one of the advantages of CT, that you can reconstruct the images in the coronal plane and in the sagittal plane to look carefully for the extent of the lesion and the invasion of the adjacent structures. Here you see the stomach, and you see the bulging lesion outside the gastric lumen. And we used to use this feature to diagnose leiomyoma and leiomyosarcoma of the stomach, but as I have said, you cannot reach this pathology unless you have the endoscopic biopsy, for example. We also use water, especially in the stomach, which is better than gastrographene and more cheap, of course. And you can see that the stomach is filled with water, and this is the normal thickness of the gastric wall, but here you can see an infiltrating tumor with irregular margin and soft tissue component along the lesser curve of the stomach, which has been proved by pathology to be a lymphoma. And this feature is almost pathognomonic of gastric lymphoma. Whenever you see there is diffuse, marked thickening of the gastric wall all around. And this thickening, which may reach 2 or 3 centimeters in diameter, is almost circumferentially surrounding the gastric lumen and, of course, encroaching on it. Then if you reconstruct the image, and you can have this picture, and you can see this is the gastric lumen, and this is the mass infiltrating the lesser curve, as well as also the greater curve of the stomach. And this is another example of gastric lymphoma by CT scan using only water. And of course, you need to inject the patient with intravenous contrast to delineate the vessels and to look for metastatic lymphadenopathy. This is irregular infiltrating tumor involving most of the gastric wall, as you can see here. And reconstructed images, you can see this is the stomach, which is diffusely involved by a neoplastic process, markedly encroaching on the lumen, which is outlined by the orally administered gastrography. And sometimes you can use the PET scan to see the activity of the lesion, as you can see here in this particular case. Then if you go to the small bowel, and this is a difficult area for the CT and for barium beforehand. But I will show some of the examples that we can use by CT. You give patient oral gastrographene, and you have a CT scan like this, and you can see multiple filling defects inside the opacified bowel loops, and you can reconstruct the images and look from other side, then you can see these filling defects. And these filling defects represent polyps, which are benign in this particular case of Budd-Sugar syndrome, which is easily diagnosed clinically whenever you can see this very characteristic pigmentation around the mouth and also in the hand. And in the era of barium, we have this examination, which was known as small bowel enema. And you introduce a nasogastric tube, and you try your efforts to bust the tube until it reaches the proximal part of the jejunum. And this is in a template, and you can see this is the tube, which is curving inside the stomach, and then you go until you reach the jejunum. Then if you are lucky and skilled enough, then you can reach the jejunum, and you start the injection of barium, and you delineate loop by loop in order to avoid the overlap of each loop whenever the contrast is taken orally. But the same idea is now applied for the CT, but instead of injecting this gastrographene, we inject methylcellulose. And this methylcellulose will distend the small bowel loops, as you can see, and you are able to see that the wall of the loop can show enhancement with contrast, denoting its viability, and the lumen is delineated by fluids, and if there is any mass, you can easily appreciate. And this is what we call CT enterography or CT enteroclysis. where you can have these images, multiple images for the body, either in the axial plane or then the coronal or sagittal reformatted images. Then you see this is an example of a desmoid tumor in one of the loops, and this loop is delineated by gastrography. And this is also one of the ways you can have it by CT, which is known as a CT visual endoscopy. And you have the ability to scan the upper abdomen, then you tell the CT to remove every structure, leaving only the stomach. Then you can reconstruct the stomach the way you like, in the axial image, in the coronal image, in the sagittal image, and you got an appearance like this, which is almost similar to that obtained by Berry. And if you look here, and you can see multiple filling defects in this virtual endoscopy of the stomach, which can correspond to the real endoscope. Then carcinoma of the colon can also be diagnosed on the same principle. And you see here a mass in the region of the cecum, and if you look carefully here, you can see a focal lesion in the liver representing metastatic deposit. And if you look carefully in this CT scan, then you can see this is the sigmoid colon. If you follow the sigmoid colon, you can see progressive narrowing of the lumen and progressive mural thickening. And this is the region of the neoplasm, which represents the carcinoma sigmoid cancer. This is an easy diagnosis of cecal carcinoma, a mass infiltrating the cecum, which is partially delineated by the orally administered gastrography. And you can have these coronal reformatted images to see the full extent of the tumor as well. And in this particular area, it's hard for you to identify the tumor, but if you look carefully, and you can see that the small bowel is dilated, and you can see multiple air fluid levels, meaning that there is some obstructing lesion here in the scan. But if you came to this area and you see some gastrography, then you see total obstruction of the lumen and a considerable mural thickening here. Then you got to the dilated bowel, which is obstructed, and this is a carcinoma as well. In the old days, we used to have these plain X-rays in the supine and erect position to diagnose intestinal obstruction. And you can, from the appearance of the bowel loop, you can approximately know the level of the obstruction. And here you can see that the dilated part of the GI is the colon. Then the obstruction should be distal in the colon. And by the help of CT, and here you can have this picture, and you can see this apple core stricture in the sigmoid colon representing carcinoma of the sigmoid. And the same idea can be applied for the colon, meaning the virtual endoscopy. You should have a thorough preparation of the patient to remove any fecal matter from the colon. Then the patient came to the CT machine, and you inject some air in the colon to distend the colon so that you can perform the virtual endoscope. Then you tell the machine to remove everything, leaving the colon only. And you got this particular image, which is known as CT colonography, which is almost identical to the barium enema without the use of barium anymore. And you can appreciate the arrowed structure. This is an apple core structure in the transverse colon, and you see the markedly narrowed lumen. Then you can obtain these images in color, and you can obtain it in black and white, and also you can have it in the 3D images as well. And whenever you obtain this image, and this is what we call CT colonography, and you see this malignant structure in the rectus sigmoid area, you can use the virtual endoscope in the machine to have this examination, which is known as CT virtual endoscopy. You push a button on the machine, which is the virtual camera. Then whenever the virtual camera is open, you put your pointer here at the beginning of the colon, and you move inside the colon like this, and you see the result on the opposite screen. Then you can go inside the colon like this, and if you hit some of the walls of the colon, you can correct yourself and come back, then go to the true lumen, then you proceed until you screen the whole colon for any strictures, for any masses, for any diverticuli. All these can be identified by this virtual endoscope. And you all know that any subject who is above the age of 50 should have a look at his colon once per year. And there are three ways to look to the colon: the very minima, the real endoscope, and this virtual endoscope. And most of the patients prefer this very non-invasive technique. We do not touch the patient unless, apart from injecting his colon by some of the air in order to distend this colon. Finally, I came to the role of CT, and actually if there is a role for MRI in identifying the tumor spread. And the CT is very good for identifying metastasis in the liver and also the ultrasound, but there are some of the limitations which give the chance for MRI to be here. Then you can see here, this is the sigmoid cancer, and in the same case showed multiple focal hepatic lesions representing a metastatic deposits. By the use of multi-detector CT, which is one of the CT techniques that facilitate the virtual endoscope, you can have this study which is known as the triphasic study. We put the patient on the machine, is fasting, and we have non-contrast scans for the liver. Then we inject the contrast material and we say to the machine, we would like to scan the liver when the contrast material is in the arteries. Then we scan the liver when the contrast material is in the veins. Then we perform later on a scan after 2 minutes from the start of contrast injection. Then we have 3 phases after injection of contrast. And because of the speed of the machine, we are able to reach the contrast material in the arteries after 20 seconds from the start of injection, in the veins after 50 seconds from the start of injection, and later on after 2 minutes. And this is what we call the arterial phase, where you can see marked concentration of contrast in the aorta, and you can see very good delineation of the lesion. Then if you look to the portal phase, where the contrast is in the veins, the lesion have disappeared. Our chance is to see the lesion in the arterial phase, because as you all know, most of the hepatic pathology is supplied by the hepatic artery, and the liver tissue, the normal liver tissue, is supplied by the portal vein. Then if you look here, you cannot see the lesion in the portal or in the delayed phase, but your chance is to pick up this lesion in the arterial phase. And of course, you don't have, or you have minimal chance to see the lesion in the phase without injection of contrast, because of the poor contrast between the lesion and the liver without contrast injection. This is an example. This is cirrhotic liver and this is the spleen, and you cannot see anything but in the arterial phase, and you can see the enhancement of the lesion. In the portal phase, you see the fainting stain of the lesion, but in the delayed phase, and this is not constant in every patient, this occurs in few patients only, when the lesion is hypervascular and it collects contrast very rapid and wash out the contrast very rapid. But the liver parenchyma collects contrast slow and wash the contrast also in a slow way. Then you are able to see the lesion in the background of the liver. Then we look at this example with liver metastasis, and this is the non-contrast study, and you cannot see, you see only the liver is enlarged, and you may be able to see 2 or 3 lesions. After injection of contrast in the usual way, and you are able to see also few lesions. But in the arterial phase, you can see too many focal hepatic lesions delineated by contrast. Whenever you scan the lesion in the arterial phase at the time of contrast material seen inside the lesions. And this is one of the important facilities nowadays available by the multi-detector CT. Then if you see focal lesions like this, and this is the portal phase, and you can see this is the cyst and this is the solid lesion. You can easily differentiate between both. But if we see the cyst and the lesion, we consider all as solid. Then we consider these lesions as metastatic deposits. Then metastases are diagnosed by multiplicity, they are usually black compared to the enhanced CT parenchyma. And as you can see here, this is the prostatic cancer with multiple focal hepatic lesions. And this is also multiple focal hepatic lesions representing metastatic deposits. Look at this case, and this is a patient with carcinoma of the transverse colon, and we injected gastrographene per anus. Then we delineated the colon, and we have the scan, and we reconstructed the image so that you can easily appreciate the site of the lesion. And also you can order the scan to remove everything, leaving only the colon. Then you can see the apple core configuration of the stricture in the transverse colon diagnostic of malignancy, as well as the presence of multiple focal hepatic lesions. As you all know that metastatic deposits from mucinous adenocarcinoma of the colon can contain calcium, and this is an example. And you should remember also that MRI is insensitive for the detection of calcium. So if you are suspecting or the calcium is very important to reach the diagnosis, then you should not have an MRI, but you should have a CT scan. Some of the metastatic deposits are hypovascular. Then if you have the arterial phase, you don't see any enhancement. But you can see these lesions in the portal phase, and you can see multiple focal hepatic lesions as well as ascites as well. Then you can see this also an example, which metastatic deposits not seen in the arterial phase but seen in the portal phase, because they are hypovascular, contrasted by the enhanced liver parenchyma. One of the diagnostic signs of metastasis is what is known as the target sign. And you can see that there are multiple rings. The peripheral one should be black. And this is the peripheral one, and the second one, and the third one. And this is known as the target sign, which is one of the helpful diagnostic criteria of metastatic deposits. And you know that metastasis can occur also in the spleen, but we used to diagnose this if there is no known primary malignancy. We diagnose this as lymphoma, because you know that the most common solid lesion in the spleen is lymphoma. And if you have lesions in the spleen and lesions in the liver, you are in the way of diagnosing lymphoma. But if you know that this patient had a known primary malignancy, then you should diagnose this and this as metastatic deposits. Then in the fatty liver, which is one of the known occurrences in patients receiving chemotherapy, the metastases are black and the fatty liver is also black. Then the role of CT is extremely limited in these particular patients. This is fatty liver containing metastasis, and here is the role of MRI. And MRI see the fat as bright and water as black. Then the fatty liver will be bright, and the metastatic deposits containing water will be black. And whenever you are looking for metastatic deposits in fatty liver, the best way, either ultrasound or you use the MRI. And this is an example, fatty liver, and this is the corresponding image of MRI, and you can see multiple focal hepatic lesions representing metastatic deposits. Also, one of the values of MRI in patients having a primary malignancy is to differentiate between a focal lesion in the liver representing hemangioma and a focal lesion representing metastasis. This is one of the good advantages of MRI, because in the T2 weighted image, you know that a hemangioma will be bright, and also the metastasis will be bright. But if you have what is known as heavy T2 weighted image, and you elongate the echo time, then most of the metastatic deposits will lose the signal, while hemangioma will persist as bright as before. Then this is an easy, simple way to differentiate between hemangioma and the metastasis whenever the picture is equivocal, to save the patient from getting a CT-guided needle biopsy. Also, the focal fatty infiltrations represent a great difficulty for those working with ultrasound. But whenever in the CT scan you see vessels crossing through the lesion, this is diagnostic of focal fatty infiltration. Any focal lesion in the liver should displace or destroy the vessels. But if you see vessels going through the lesion, you are dealing with focal fatty infiltration. One of the main advantages of CT over ultrasound and MRI is to detect lymph nodes, especially in the region of the porta hepatis, and these lymph nodes may result in biliary obstruction, and you can see also dilated intrahepatic biliary reticles. And this is an example of a GIST tumor in the stomach with enlargement of the regional lymph nodes. Also, CT is more beneficial in the diagnosis of peritoneal spread and the diagnosis of omentum deposits, like in this patient with carcinoma of the stomach, and you see the extensive infiltration of the peritoneum and omentum surrounding the lesion, and in detection of what's known as omental cakes, and you see this is a very big metastatic deposit in the omentum displacing the colon posteriorly. The patient had also ascites, and thank you very much.